let's move to the first block of discussion with Catherine Musioka, Adeyinka De Folarin, Karani Maguta, and Maurice Mutisia. And apologies if I have destroyed anybody's name here. What I'm going to do is I'm going to pass each of you some of the questions that have been submitted prior to the conference, either by us requesting questions to people or through the online system that we set up, and try to make those questions representative of the different questions that were submitted to you. And then I want to remind everybody to keep dropping questions in the Q&A in the Zoom. If anything cannot be addressed during today's session, we will pass them to the online forum and we will ask the speakers to go there and answer. So to just go straight into the flesh, I will start with Catherine, since she was the first presenter for today. Catherine, you showed us some really interesting research on substance abuse by first-year university students, and several people have asked about the particularities of those first-year students and noticed the relevance of knowing more about their risky behaviors, especially as a way to inform policies that govern student housing and the educational campaigns that may target this population. Now, do you have, Catherine, any information about the role that socioeconomic factors may play in those differences that you have observed between students accommodated in public versus private hostels? That would be the first question. And then the second question, do you see any possibility of applying some of the regulations that may contribute to the lower substance use in public hostels to those that are run privately? I will ask you to start on your video when you are when each of you is responding to the questions. Catherine, you're muted.
Oh yeah, I'm sorry. Thank you, Marta, and thank you for those very informative questions. Yes, socioeconomic status plays a role in substance use among students, especially first-year students, because most of the students who are accommodated in campus are on government public sponsorship, and these are mostly students who come from lower socioeconomic background. The students who are accommodated in the private hostels are mostly self-paying students. They are privately sponsored, meaning they are able to afford that kind of cost. And this also comes with affordability for substances of abuse, including alcohol and cannabis, which is quite prevalent. Yes, so that is one of the major considerations we found out. And it was also that at the university, the other thing is those who are accommodated at university hostels, the regulations actually apply at the university. And those who are outside, there's lack of regulation. So the general, especially the national regulations here in Kenya about Alcoholic Control Act would apply more at the university setting than in the private accommodation setup, where there is more leeway. The other thing we found is students at first year are peculiar because they are transitioning from secondary
I think we have lost
college
Catherine.
level and vision of students and young people with substance use. That's what I'll say about that.
Sorry, Catherine, we lost you in that last bit. Would you mind repeating that again, the peculiarities of the first-year students?
Oh, sorry. Yeah, if you can hear me now.
Yes.
First-year students are transitioning from secondary education to higher education. And we've seen from research findings that when students, especially young adults, are transitioning from one stage of their life to the next, like over Christmas period, like this time when they've been in holidays and they're going to a new class, they're at danger of starting substance use. When they're moving from secondary education to higher education, they are at danger of initiating substance use. And now, if they get to a situation where they have left the comfort of their homes and the support and the supervision of their parents, and they go to an unsupervised environment, that puts them at more risk of substance use. That's what happens in the private hostels as well. Thank you.
Thank you. Thanks a lot. That's very interesting, and let's hope that you will continue doing research in that area and providing evidence that can help, can guide policy on that respect. Now to you, Adeinka, it is really interesting to hear about research on mental health services in Africa. As a foreigner myself, I have to say that it's not a research topic I traditionally see coming out of Sub-Saharan Africa, and yet it needs great attention. If the barriers to access to health services in general are significant, when we talk of mental health, the problems, as you have presented, only um, multiply. So you have presented very interesting insights on the community perspective about the provision of mental health care at primary healthcare services, and also, and this is so interesting, the cost of community sources of counseling that actually appear spontaneously in a self-organized manner. It seems that by offering mental health services at primary healthcare level, not only when they are not only making service more accessible, but it also removes part of the stigma and makes it easier for other support structures to develop. So what do you think are the implications, the policy implications of your study? What does it take to provide these services at the primary health care level? Don't forget to unmute yourself.
Hello, Martha.
Hi.
The question again.
Yeah, I was asking for what do you think are the policy implications of your study? What does it take to provide those services at the primary healthcare level? Since you have shown that once they are provided, all these barriers disappear, and even community support structures also appear.
Okay. Thanks for the question. Well, what it takes to have this service at the primary healthcare level is not difficult. I don't know why it's not happening. It's just training the personnel, training the staff, and there is already mental health gap document that can be followed. But this document is by WHO, is put in place, but the logistic to get it, put it in operation is still lacking. It applies to all medium and low income countries. This document is meant for all medium and low income countries. But so far in Nigeria, it's not, mental health service is not yet integrated into the primary health. But what it takes is training staff using that mental health guideline by WHO.
So are you
But
planning on doing
the
some...
will of the government is very important, political will to do it.
Are you planning on doing some policy engagement with maybe local governments to see, to show them the evidence that when this is done, it works, as you have shown.
Yes.
And it's even
Yes.
amplified by the community itself. Have you done any
Yes.
plans to engage?
Yes, there is a plan, and there was an attempt in the past. But then, in the state where I am, and there's a local advocacy, the governor of the state said he was not interested in mental. Sign.
Sorry about that. I think we have lost Adeinka. Adeinka, we had lost you. We haven't heard what you've said, and now you're muted.
Oh, sorry.
Yeah.
Can you hear me now?
Yeah, now you're with us. It seems.
Can you hear me?
Yes, it seems your connection is a bit weak. Maybe you can put off your camera and see if it works better. Sorry about that. I think Adeinka is having connectivity issues. We all know what that is. Internet is not always there when you want it. So we are going to move to Karani Maguta now. Karani, I think you brought a big elephant into the room. Changes in lifestyle are creating new problems and also exacerbating others that were already there. And you bring up, they always talked about moderate exercise as a way to reduce the incidence, in this case, of hypertension in older adults. Now, can you describe the exercise routines that you used in the equivalent that any of us can do near our houses without subscription to the gyms? And also, have you made any attempts to bring this information to the community? Have you engaged the media or any community organizations to disseminate your research findings to implement maybe a study at a bigger scale using exercise routines that the common citizen can do with little interference to their lives?
Thank you, Marta. I am not able to have my video on from my side. I'm told I'm stopped by the host, but I hope you can get me.
Yes, please.
I can
go
proceed.
ahead. We will try
yes,
and
I
sort
think
that
the
out.
video is not coming.
Okay.
Yes, I am sorted now. Thank you. You asked me to describe the exercises that were done and how we are comparing this. So moderate intensity exercises entail exercises that can be done when one is able to talk but cannot sing. That's the most basic explanation of it. Any activity that you can do that paces your heart, you are able to talk to somebody next to you, but if you wanted to do your favorite song, you cannot. But there are more scientific ways of doing this. We can work with that for now. So this is what we compared for individuals who would do this so that they have the same intensity, but individuals who would do this in shorter sessions of about 7.5 minutes, but done 3 times in a day. And so that the cumulative time for doing this would be equal to those who did the same as advocated and prescribed from the WHO guidelines that advocate for 30 to 60 minutes of similar intensity sessions done 3 times in a week. So the main thing here was to prescribe shorter bouts of exercise, but maintain the intensity, but cause the shorter bouts to be repeated with the higher frequency, but so that in a week, the times are equal. Now, you asked what attempt I have done to make this rolled out, probably at policy or at community level. What I have started with is to enlist and communicate this from a local perspective, and where we are starting local clubs where individuals do aerobic activities, they do activities that pace their heart, endurance exercises, but starting from a local perspective where we are rolling this out with locally organized exercise clubs. So that we have, and yes, we have one running locally where I live. Thank you.
Thank you. Thanks for that. Some of us are going to apply your research findings and then push ourselves off the chair 2-3 times a day instead of hoping for a long evening walk at the end of the workday. Thanks a lot for that interesting presentation and the discussion. Let's now ask Maurice. Maurice, you presented a very valuable information about the evidence available about what works and what doesn't work when it comes to improving nutrition of children in urban informal settlements. But it seems actually people are very interested in how you have conducted your research. Several people in the audience have sent us questions that are more focused on the methodology and how the way you've performed your research and how this way can inform future research by your group. What you have presented is a very interesting combination of synthesis of existing evidence and then involving the stakeholders to hear what they consider that are key areas where more evidence is needed. Now, how is your group using these findings to design the next steps in your research project, and how are you planning to keep the stakeholders involved in that design? That would be the first question. And then can you give us your view of the support that programs like CARTA can provide to researchers to ensure that the researchers we train are competent in this co-design with community and stakeholders?
Thank you, Marta. Thank you, team, for listening. I hope you can hear me, Marta.
Yes, we can.
Okay, yeah. Thank you for the question. This work, when we began, it was out of engagement with policymakers at the very beginning, and what we did in some of the forums that were with the policymakers, I tried to highlight some of the areas that they thought they needed some more understanding. And what we did is put in a proposal, and we got some funding to be able to put in a team of UK, Kenya, and the policymakers in Kenya, Malawi, to be able to look at what is happening in urban informal settlements. But besides also the work that PHRC has done into urban informal settlements in Kenya. And at the initial thinking was, what's the best way of teasing out this information? There was a literature review which was done by Goddard. It was until 2004, and much of it focused on children that are under 5, but it brought on some gaps as well. So when you review that, then we realized there are some more gaps in terms of the infant and young child feeding practices, and especially complementary feeding. And the major actually elephant in the room was what kind of methodology can we be able to use. So to answer your question is, policymakers were part of this process, the Ministry of Health in Kenya and Malawi. We also had AFCAN, which is the African Child Network. Then we had the Ministry of Agriculture and the Ministry of Education being part of the team. Although when we were doing the Delphi technique, we tried not to target them to provide responses because majority of them were part of the process. We tried to target academicians and practitioners in the different sectors, and that's the beauty of the approach, because it tells you reach to the people who have expertise and who know the subject area. Then they can try to give you information of what is what is happening. And out of that, currently we're implementing a study in one of the local areas in Kenya called Kajiado, and it was as a result of this when we disseminated the findings. The team in Kenya came and asked us, do you know what is happening? We are talking about urban informal settlements, and we know there are also other marginalized populations like the nomadic. And out of that, we designed a study which we try to understand what's happening in the nomadic and to be able to compare the results to inform us the next line of actions. When you're talking about how do we bring these complementary methods to CARTA, I'm not sure I have an answer to that, but the exposure to different methodologies is usually very key. Initially, I never knew about the Delphi approach, but working collaboratively with other partners and the stakeholders in the process, some of these things came up and we were able to implement. In the current study, we're actually even using photo voice, another technology, another way of collecting information in a very detailed manner to understand the community context. So for CARTA, I think probably is mapping out the different people and the different methodologies that they try to use, and try to see with the partners, with the graduates, and with the students, also mapping them to get to know what methodologies they are interested in learning, and then we can design some trainings around that. And I'll be very happy to facilitate photo voice. I'll be happy to facilitate the Delphi technique. Thank you, Marta.
Thank you for that. Be sure that we will take your word and we will call you at some point to facilitate that training. We will give you room for that.
Thank you.
To have that opportunity. Now, this is a very interesting discussion. Time is flying and we are running a bit late. So we are going to move on to the next, the other 4 speakers, and try to get at least 1 or 2 questions to each of them. I continue encouraging people to submit their questions through the chat and the Q&A section in Zoom, so that the panelists can continue answering through there, and then we will also take them from there to the online forum, and we will try and engage with as many of you as possible. And remember that the questions that I'm posing are questions that people have already submitted before. So we will do our best to also address any question that comes in during this time, but to try and make it more time efficient. I'm now welcoming back Rose Apio, Dube Nkosi Yazi, Chimwemwe Banda, and Respicius Damian. And again, I apologize if I have stepped on anyone's name. Without any protocol, we are jumping into the science again straight away. Rose, hello again. What an important study you have presented. How many diseases require patients to control themselves when eating and adhere to a strict diet? And how little do we know about what patients think about those prescribed diets? You have taken a very interesting mixed method approach that shows that what is tilting the scale towards not non-adherence, which factors are are pushing that scale towards the non-adherence. A couple of questions to you from other participants and the audience. First would be, did you find any correlation between adherence to the diet and the health outcomes during your study? And the second question would be if you have concluded, you've concluded your presentation sharing with us a really nice plan for dissemination and further development of interventions that can improve adherence. Do you have any plans for that intervention to be implemented? And are you planning on doing any follow-up study of adherence after those interventions are implemented?
Thank you very much, Martha, and everyone else, and the questions that you've asked. Now, the first question is whether we found any association between adherence and the health outcomes. Now, among we did collect much data on the clinical parameters, particularly on nutrient levels that could affect the health outcomes. But we collected data on the comorbidities, particularly the diabetes and hypertension that are most common features in patients with kidney disease. And apparently we didn't find any significant association between these comorbidities and adherence to the diet prescription. There was no association in our data.
Okay.
The next question that you ask is on whether there are any plans or follow-up study on the recommendations that we have. Yes, I'm really looking forward to be able to carry out a follow-up study on any of the recommendations. We had quite a number of recommendations, but currently we have at least discussions with the stakeholders to see what can be done on some of these recommendations, particularly on the fact that currently we don't have the local renal nutrition guidelines. And so we are discussing with the ministry to see, and the ministry and the health facilities and other stakeholders, what is it possible to develop the local renal nutrition guidelines based on locally available foods? Because currently it's mainly based on international guidelines. And some of the foods that are recommended to the patients, they find that they just have to buy them because they can't locally produce them. And yet there's a lot of locally produced foods. And so because we also have the national, we have the national food composition database that was recently launched in 2018. Unfortunately, that has not been disseminated, or rather the nutritionists have not been trained on the use of this resourceful document to be able to use it in their counseling. So I think with that, if that is done, and then with the development of the guidelines, then that would be something wonderful. And that's one thing that I'm really trying to follow up to see if it can be done. And I look forward to that.
Thank you. Thanks a lot for that contribution, Rose. It really seems very important to bring in the local relevance, as you've mentioned. I know there are a few people working on food security at APHRC, and the work they are doing around people having access to food, of course, rich foods, and in the case that you're bringing up, the foods that are being recommended to control their own diseases, for self-management of chronic diseases. They are all very important studies. Thanks a lot, Rose. And we all hope that you will get the funds to continue doing that research and
Thank you.
bring the impact of your findings to the community. Now, moving to social protection, Dube, you have taken us to thinking about the role of Stockwells, and I hope I'm pronouncing that correctly, and how important it is to know more about the ways that in which communities are finding ways to meet the health and social protection needs of the women members of these communities. Now, seeing how important they are, these Stockwells for the members, and thinking of the possibility of them being formalized in a way, institutionalized into the mainstream service delivery and the general economic systems. What are the current policies and maybe the possible implication on the role of Stockwells as far as social protection and health protection promotion, sorry, are concerned?
Thank you so much, Martha, and thank you, colleagues, for the questions. I think you are raising a very important question here, especially in terms of formalization. That's what I'm just going to briefly talk to. Formalization, it's kind of partly happening. There are some stockfiles that now registered with formal institutions or work in partnership or in collaboration with formal institutions within the South African context. But I think the unfortunate part is that even those stockfiles are a very important part of social protection, and also they enhance both the educational, the social and economic needs of the members. In terms of the policy area, they have not been seen as that important. They have not really attracted much in terms of government intervention or being used broadly to support the women, especially in terms of their health-related needs. So what we have done here, especially in this study, we are trying to say, let's look at these informal systems differently. They are already working and they've proved to contribute to the social protection needs of the people, but let's explore them further. I'm even thinking of the current COVID-19, that those are the indigenous structures that we can start with in order to reach even the hard to reach populations. So it is very key that, you know, these are taken seriously and they are seen as contributing even to the health needs of the women. So in terms of the implications, so we have, after this study, it then gave birth to the current study that I'm doing with the colleagues as a team, where we are looking at how are these institutions, the possibility of using them for hypertension screening for women, just to start the process of saying, if there is that possibility, can we then introduce that intervention? And then we see the uptake, then we take it from there. So it's still a very developing idea, and we are still trying to initiate more debates and to involve quite a lot of a number of stakeholders into this process, so that at the end of the day, we realize the potential that we see at the end of the study. Thank you, Marta.
Thank you, Dube. I can see 2021 full of community and policy engagement activities. I hope this year is going to be the one in which CARTA takes off as policy advisor and engagement, engaging the communities. Thanks a lot for that interesting contribution. Let's try and drop one more question to each of the two speakers who have not participated yet, and hopefully if they are brief enough in their answers, we may get to fit in one or two more questions from Jude and maybe from the audience. But I really don't want to go past 15 minutes after the hour. because I know people have responsibilities and other life to live after science happens. So Banda, now thanks for such a passionate presentation of your research. Now, in your case, and because COVID-19 and diabetes have been so closely related, I think the questions came on that angle. Now, can you discuss the interaction of the current health crisis with the barriers that you have identified in your study? And also, you have mentioned a follow-up on the integration of these services in primary health facilities. And can you give us your comments on how this continuation study is being affected by the current situation?
Yeah. Thank you very much. I'll not be able to start the video because it's been stopped by host. The first question regarding the effect of COVID, and or rather the interaction of the effect of COVID as well as prevalence of diabetes. The observation is that it exacerbated challenges with accessibility to services, in that at the time when COVID pandemic was at a peak in the country, the clinics were stopped at the central hospitals. So people were only allowed to come for medication refills, but they did not have to do any consultations or assessments. Now, knowing that the health primary care facilities in the country were not providing diabetes services yet, it meant most of them were only living on their medication or managing themselves in whatever means with minimal monitoring. Unless they were acutely ill, then they had to come to hospital for management like any other emergency. However, there is no empirical evidence on how this has really affected their lives, as we haven't gone back to assess people or ask them of their experience whilst their clinics were closed. And in the second question, where you're asking about the second phase of the study, this second phase was done just, or rather finished just before we came to a slowdown because of the COVID. We really never had a lockdown, but a number of public gatherings and services were slowed down. So I managed to collect the data to do the needs assessment for the primary healthcare facilities and their capacity in management of diabetes. And the findings really showed that most of them were not yet capable to provide diabetes care services, mostly due to limitations in the staff capacity. Other facilities did not have the right medication for diabetes or any other NCDs, but also limited equipment and resources. So they're ongoing, because this was like a needs assessment, but also the study was embedded in a larger national study that's doing a national needs assessment on non-communicable disease capacity for the Ministry of Health. So there will be other implementation studies to as follow-up to help improve access to services. Thank you.
Okay, thank you, thank you. That's very interesting. I'm glad the needs assessment could be finalized before the lockdown, and I'm looking forward to seeing those publications coming out, and hopefully those recommendations and those conclusions that you've extracted will inform what the governments will do to support those health facilities. Really provide the service that your research shows it's so needed. So now finally Respicious, who has been putting that the magnifying lens in accountability, and you've actually gone to the community to test very interesting bottom-up approach to improving accountability in primary healthcare services. Two questions for you, Respicious. One, what is the role in of the community in the initial budgeting of that of those budgets that they are monitoring, that your intervention was asking them to monitor? And two, you have used your postdoctoral grant to engage the community in as a solution to a problem that you identified during your PhD. Do you have any plans to now continue the trail and engage policymakers in Tanzania to take these important recommendations of your postdoc one step further?
Okay, thank you for these interesting questions. In terms of the first question, which is on participation in the budget, I'm not sure if you are referring to the budget for the intervention or for running.
No, the budgets, your intervention is asking them to kind of be agents of accountability, right? That
Yes.
Some budgets are being implemented, that the services are being provided. Do they have a voice before those services, like in the decision making of which services need to be provided? Where is the money being spent? Or are you bringing them as a tool for monitoring and evaluation, but they are not empowered before to actually engage in that process?
So we have the policies and the laws, actually have the platforms for participation in decision making and budgeting. And we actually have the health facility committees, which are supposed to approve the budget. But that is actually theoretical. In terms of their participation, it is limited to actually approving the budgets which have been developed actually by the facility management teams. So once they are there, what is needed is actually the signature and not the influence on the process. And through the engagement, we were trying to make them learn how to steer the process. For instance, they have to develop the action plans for the engagement itself. They propose how much they want to use, then you give them you approve the money, they do the engagement. So that we were trying to build the virtues of being engaged, being ready to participate, and actually building the trust towards the health workers and the service providers. But for the second question, which is also important to do with police engagement, primarily we didn't have a plan to do what is called policy engagement, because our essence was actually to empower the communities, to change the behavior, and to work with service providers and government at the local level to address the health challenges they have. But I think as a next step, like what I have said about the extended engagement and extended partnership, the policymakers and national level actors, they need to be involved actually. And not only the policymakers and government institutions and providers, we have a role as scientists to put the communities at the center of science, make them understand the process, and actually steer the process itself to influence the change in the policies at local and national level. Thank you.
Thank you, Respicious. That's a really nice conclusion, actually, and I think it wraps up very well everything that we've been doing here. I can see a lot of policy engagement coming out of all this great research that you have all been doing. Now we are just past the hour, but I have seen the chat and the Q&A. I've been keeping an eye on them, and I have seen Anne Nangulu very, very keen on submitting a question and maybe posing that question. I'm going to ask Gloria to allow her to talk, or maybe I can do it. Anne, you can go ahead and pose your question or bring your comment up.
Yeah, thank you very much. I'm glad I've seen all of you. And I just wanted to ask, first of all, to congratulate this CARTA team. Some of us who are old in CARTA, we have seen all of them come of age, and we are very happy. And some of us who have institutional memory of CARTA, we are glad that this is happening, and I had to look for time to attend. I would like to raise a few issues. They might not respond, but these are very pertinent issues to us. First, I appreciated the presentation by Jude, at least to give a review of all the presentations which have been there attentively, all of them. The matter of policy, I think it is a high time that the CARTA fellows take it even at institutional and also at national level, and maybe we use the platform as suggested by Jude, that we start maybe doing some advocacy to influence how these matters of policy can come in. Particularly, I was very keen to the neglected research areas based on the audit of research as Jude has just recommended, that maybe this is one area that we need to make it more visible as per the recommendations, and maybe see how we can even attract some of the PhD students to undertake the research of the areas that need further audit and also neglected figures. I'm also keen about the Karani's presentation. I was just very keen, just as we all have been keen, in terms of recommending the exercises. Is it possible, maybe we should do a recommendation even at an institutional level? How do you encourage people who are working? For example, if you are at a place of work, how will you execute the 7 minutes? Of course, if you are doing it, maybe, as you said, 3 times a week makes sense. But in the morning every day, suppose somebody is doing it at 15 minutes every day, will it still have the same effect, or you are looking at it? Because the logistics at work is what I was waiting for you maybe to give a comment on it. How is that being managed? The issue of infectious diseases and substance, particularly the substance abuse at college level, this is very rampant. I expected also a sharp recommendation. Maybe the presenter need to rethink about it. The small research we have even done, even where I am now and at Mo University, we are also now finding out that it's not even the poor or kids from poor background that are using drugs. In fact, those from the high-end families, because they can afford. So maybe it is also another area you can look at it, in the sense that the other research is giving otherwise. But I just want to say that this is very good, and I'm congratulating all the presenters and the sharing of information. Thank you very much, Martha.
Thank you, and thanks for that comment, and thanks for being with CARTA from the beginning and taking it all the way up to here.
Thank you.
I want to maybe give Jude a minute to ask some questions or make a comment about the general presentations, maybe ask them a few questions, but very briefly. We want to finish in 5 minutes.
Okay, I'm happy to take questions, but more importantly is the challenge I've posed to CARTA fellows to say if it's a challenge they're willing to take. Because there's a lot coming out of CARTA, and it would be inadequate to say we stop at writing these papers. We should be the change makers that CARTA envisions, and in doing that, we need to translate this research into practical policies, like Prof. Anna Angulo has said, that we must think of using this platform. And frankly, those who came before us, like herself, have brought CARTA this far. And the next step is really now for CARTA fellows really to embrace this challenge and come on board to see how they can participate. I am open to facilitating and supporting the system with Martha If you have questions, feel free to come back to me, but we are now in a place where we are better able to look at thousands of publications very rapidly and generate a lot of good summaries that are able to change policies. And more importantly, if you look at the entire CARTA ecosystem, the way your work complements each other without even knowing. I already gave example of the end-to-end from Maurice to Fagbemigbe. In between there's Nicole. There are many others, that, Justin Bukea may not know, but her work is very much related to what Admire is doing. And right in the middle, there are other people who are also doing all kinds of other things. So there are many CARTA fellows working in pockets who don't know that their work are very complementary and answering the bigger and more complex questions. And we need to get into that space to begin to address such issues.
Thank you, Jude. And I think I'm gonna leave it on that call to action for all fellows. We have 18 here as panelists and participants. Some of them presented today, some of them will present tomorrow. We've had up to 90 other people, many of them also fellows and graduates, and a few others that I don't know the names, so I'm hoping they are from outside the CARTA family. And that call to action for everybody to not only focus on your small research and getting your project done, but also looking out towards other CARTA fellows, other institutions are doing, and how the work can increase the impact if we use the synergies of those alignments and those possibilities for collaboration. The impact can be much bigger than just the sum of the small parts. So here we put the end to today's session. We hope you enjoyed. I certainly did, though I'm sweating nervous, facilitating the first ever scientific conference for CARTA, and also doing it virtually because it has to be in these COVID times in which everything is different. Thank you, everybody. I hope you enjoyed, and I hope to see you all and many others that you will call in for tomorrow's session. Stay safe, stay distant.
Sorry, Martha, those
Martha, congratulations also for you for hosting the conference.
Thank you.
Thank you very much, Martha.
Thank you.
Bye, everyone.
Bye.
Bye.
Bye-bye.